All right. Hello, everybody, and welcome to Airway Answers, Expanding Your Breadth of Knowledge. And we are here with the wonderful Dr. Pat McBride. Let's see if I need to lower my volume just a bit. I was having a little bit of echoing there. All right. Thank you so much for being here, Dr. Pat McBride. Let me do a little intro about you. Dr. Pat McBride has spent 41 years as a full-time clinician and educator in the fields of dentistry, respiratory medicine, and sleep medicine. Her extensive experience in clinical, laboratory, research, and educational arenas has led to the development of interdisciplinary care model delivery systems used by physicians and dentists around the globe. Pat's publications span both medical and psychosocial spectrums. She has a unique ability to intervene in the interstices of global systems, developing protocols which can be translated across demographics and cultures into improved clinical outcomes. She sits on the board of directors for the American Academy of Physiological Medicine and Dentistry in New York, and the AAPMD's Endeavor Pediatric Community. She continues to work hands-on in a clinical setting and as the executive director for the Foundation of Airway Health, while lecturing internationally on subjects relating to breathing and sleep medicine, dentistry, and precision medicine systems to best benefit all patient populations. Serving the underserved and marginalized patient remains a passion and a priority for her. Thank you so much for joining us, Dr. McBride. Today we're going to be talking about hypoglossal nerve stimulation, but I did want to talk really quickly about your beautiful backdrop. That is not a fake screen. It's Pat's backyard, a photograph of your backyard. And I said it looks like Italy, or you're in like a vineyard in France or something.
This is where, if I'm not working, if I'm not writing, if I'm not working, or I'm not seeing patients, this is where you'll find me. So if you
I'm coming over.
Yeah.
So it's just so lovely. What a great place. What a great space to have at your home. So I wanted to talk to you about hypoglossal nerve stimulation because I feel like it's a topic that I don't hear too much about in terms of tons of patients receiving this treatment and what exactly it is, how it works. And I know you have a specialty in this area. So can you talk about how you have the specialty working with the hypoglossal nerve stimulation? And then we'll talk more about what exactly it is.
Sure. So being with the sleep apnea community, sleep apnea therapies, everybody is always looking for something new, different, novel, something other than, for instance, CPAP, which is what has been the gold standard for sleep apnea therapy for so long. And back in the early 2010s, I had heard about this new stimulator that was being developed. Originally, it was part of Medtronic, and then it kind of went away. And then it was a group of the guys took it out and started working on it independently, called Inspire. And they developed this neurostimulator. It's a means by which, like a pacemaker, they developed theoretically a pacemaker for breathing. So what that would do is allow patients who couldn't, wouldn't, or didn't use CPAP, for instance, didn't want to have craniofacial surgery, didn't want to have expansion orthodontics, which really were not in the heyday at that point. It allows for a different kind of sleep apnea therapy for those patients that really fit the right model for it. So that was originally, I read about it. It got approval and was started early implants in 2013 in Europe, in Germany for the first part. And then 2014, it received FDA approval. So it was considered very novel in 2014. Now in 2024, I would say it's part of mainstay sleep apnea therapy. It's certainly not the first thing that's offered by sleep medicine doctors as a treatment paradigm for their patients. However, it has become part of the tool bag that is used for sleep apnea therapy. So having said that, it's like a pacemaker, people do need to understand that hypoglossal nerve stimulator and or Inspire, which is the brand name of the product that's used here in the United States, that was the first product that received FDA approval. There are others that are coming up through the pipe now that would be competitors that use the same basic type of technology, which allows for the hypoglossal nerve. If everybody sticks their tongue out, you stick your tongue out, your airway opens up. So when you stick your tongue out, that nerve fires the muscles that move the tongue forward. The goal when you have obstructive sleep apnea, obstructive being the word, that your tongue falls back and obstructs your airway, shuts off the oxygen to you whilst you're breathing. So if there's a means by which we could stimulate the tongue to move forward out of the airway and keep the airway open for the intake part of for the inhalation part of the breathing cycle, then if there was some sort of mechanism that could do that, then you could treat sleep apnea effectively using something other than forced air, for instance, which is CPAP. So what hypoglossal nerve stimulation does is, by virtue of a very small electrical cuff that's placed along the hypoglossal nerve. So this is surgery. So it's not something you pull out and stick on. This particular thing is surgery. They make a very small 5 millimeter incision usually kind of under the fold in here, locate the hypoglossal nerve, and there is a cuff. It's a silicone cuff with 3 gold electrodes that closes on itself. So if this is the nerve running this way, the nerve looks like this, the hypoglossal nerve. So the fibers at the top of the nerve, so here's the body, here's the break points are out here. This is where it all comes together, okay? So if you're looking at this, then part of this nerve makes the tongue go forward, and part of it makes it go backwards. Well, what you don't want to do is stimulate this nerve to go backwards, right? You don't want the tongue being pulled into the throat. So what they do is, when they're going to put this little cuff under here internally, they test the nerve, all these little branches, and see which one of these, when they test it, goes backwards and which one goes forwards. Then, for instance, these bottom 2 go forward. They capture one of the cranial nerves, number 1 down here as well. They put this cuff, it just self-closes around the nerve like this. They keep the ones that make it go backwards out, the ones that make it go forward when you stimulate it. So you stim it, beep, and it goes forward. It opens the airway. So the cuff goes under the neck, and then it's attached obviously to a wire tube, a little feed cord that is fished under the skin down to a generator pack that's placed just about the 3rd rib height down. In the old days, it used to be 3 incisions. It used to be the electrode was under the neck, the generator, which is the battery pack, essentially like a pacemaker. It essentially looks exactly like a pacemaker. So anybody who's seen a pacemaker before knows that it's a little battery pack. And then they used to have a respiratory sense lead way down here between the 4th, 5th ribs. But that has been modified, that surgery's been modified and improved so that in the same place the generator goes in, they're now able to put that sensor, that senses when the breathing happens. So the respiratory sensor, which is the other little piece of equipment that goes underneath the battery, senses when the actual breathing cycle starts. So it senses the minute you start to breathe in. Well, as you start to breathe in, it sends that little signal up to the tongue to move backwards. Allow the air in. Breathe in, wide open. Okay. As you finish inhaling, the respiratory sensor notes that you're starting to exhale. It stops the stimulation and allows the patient to exhale normally. In, stimulation on, exhale off. So it syncs with the breathing cycle so that you can breathe normally while you're sleeping, and it stimulates enough so as you inhale, instead of sucking your tongue down your throat, the tongue is being stimulated forward out of the airway, keeping it open.
And the generator, it's
low battery that comes right here.
Up on the 3rd rib. Up
here, right here. Yeah.
Okay.
It's tight. Now, for some ladies, there are some very cool surgeons who deal with women. One of our patients was a ballroom dancer and who has their décolletage. It's very important. She can't, and was thin, very thin woman. So we hid You can hide the generators. I know that may not be on label, but there are plenty of surgeons who want to make sure the aesthetics piece is taken care of. And they make their own decisions about that so that it's hidden. Nobody sees anything. Very, very thin people. One of the marathon runners that we got had an original one. The battery was twice the size on the ones 2014. Had his battery swapped out, I think in 2022, but he'd also lost about 65 pounds. So he needed something different. It's actually very easy to put in, very quick. It doesn't take very much time. It's no different time-wise, as I've seen, having been in cases for over 4 years, than putting a pacemaker in. It's just quick, easy. You go in the morning, you go home at lunch, it's all good. And then, but it's a process. There's a way you have to be qualified for it. That's the actual surgical implant itself. But whether or not it is the right treatment for the right patient at the right time is a very different thing.
That I have a lot of questions about that because I'm really curious, but a couple questions about the implantation of this device. It's called a device, right?
Yeah.
Device. What is the size of the generator? Like a few inches, but
no, it's I would say, I used to have a sample here, I don't anymore. It is about 2 inches wide. Think of it kind of like 2 inches wide by 2 by 2 maybe, and then maybe a quarter of an inch thick.
And then it's just staying externally. How does it stay?
No, it doesn't stay externally. It's implanted on top of the muscle, under the skin, on top of the muscle.
Oh, so you're going to see sort of an elevation.
For some people, it's usually down far enough that you have enough fatty tissue to cover it on the top. So
there's nothing external.
Nothing's external except for the remote control, which looks a whole lot like like a large computer. It looks like a mouse. I would say the remote control looks like either a glorified television changer or garage door opener or a mouse. It's kind of that shape and size. And that's external because you have to be able to turn it on and off externally. So mouse
all day.
Off all
and then
day.
When you go to sleep, you turn it on. What about when patients take a nap? They're probably supposed to turn it on.
It depends on how long their delay is. So patients heal for a month to 6 weeks, and then they go back and the doctor turns it on. Okay. And that's a whole process in and of itself too. And so, but in order to use it and use it effectively, you need to be able to have it on most of the night. And patients, for instance, who have problems going to sleep at night, for instance, their delay, you can have it set to not turn on for 45 minutes, let's say. I take 45 minutes to fall asleep. You don't lay down and just turn this thing on when you're wide awake.
Yeah, that would be weird because then you would breathe in, your tongue would come forward.
Tongue would be moving. So what they do is they find kind of the sweet spot for when you do fall asleep. Let's say you fall asleep in 20 minutes. They'll set it for 25 minutes to turn on. So for the first 20 minutes, your partner may go to bed and be snoring their head off because it hasn't kicked in. They think, let's say they fell asleep at 10 minutes instead of 25. So for 15 minutes, they're snoring their head off and then it kicks in and then they're quiet.
So it can't actually sense when the person's asleep.
No, it does not have artificial intelligence. No, it can't. It senses the rhythmic cycle once it's turned on. It has to be turned on, activated.
Okay, don't you think maybe that's going to be connected to like a sleep image ring or something at one point, and it's going to wirelessly or something sense when the person starts to act, when they actually fall asleep, it automatically turns on?
Well, that would be
that was just all of a sudden my brain went to like the next level.
I think that would be presumptuous for us to think of that at that point.
Probably not necessary.
Because sleep image, that's cardiopulmonary coupling. It's now considered a level 3 sleep diagnostic, like a home sleep test. They give us an idea of what's going on. They are not pinpoint accurate.
Yeah. So this is just at a set amount of time.
It'll turn on.
20 minutes, whatever. It always is going to automatically turn on.
It's going to kick in. You cannot change your delay. You have to have, there's a programmer that's used it used to be, at least back when I was doing it and I was working with the doctors directly in it, you'd have the Inspire clinical person there with the programmer while you program the patient and you've got a feel for what their sleep patterns were like. And then you dial in the needs. But the patient just can't change when their on-off time is. They have to go to the clinic and somebody has to hook them up to the programmer and have it connect and then make those changes. So you want to take your time and make sure you dial it in. There are a lot of any kind of stimulator, neurostim therapy tends to have an algorithm. Okay. Well, most medicine has algorithms. Your A1C gets to be this level, you get put on metformin. I mean, it's like, okay, get in line. Okay. Sleep is so complex. Sleep apnea there are complexities about it that go with each and every person that make programming Inspire far more difficult than people actually think that it is. Really good providers are really good at this. Other providers are less good at it because of time constraints, because it takes time. These people, they come into your practice, the ones who they advertise, they switch it on and they go merrily on their way and their apnea is cured and they're fine forever and ever. Amen. That's great. Wonderful. I'm so happy for you. That's not everybody. And sometimes any provider who is going to listen to this, who is in any specialty of any kind, will tell you it's that 10 to 15 people, 10 to 15% of the people that you see are the people that keep you up at night and are your time sucked during the day and make doing what you do very difficult because it's not easy for them.
Yeah.
And so you have to have a reasonable amount of perspective when you do any kind of therapy like this. I will definitely never, ever say this is not good therapy. I think it is excellent therapy for the right patient at the right time for the right reasons.
Okay. Well, let's talk about who is the right patient. So who would be eligible or recommended for the Inspire hypoglossal nerve stimulation?
So from the adult population, of course, the 18 up, from the 18 years old and up, moderate to severe sleep apnea, which means your apnea can be as low as 15, as high as 100. So moderate to very severe apnea, 15%. Cannot be morbidly obese. However, it used to be the BMI had to be under 32. That was when the FDA approval came through. And then slowly it started shifting a little bit. In 2023, I think it came out that the indicator changed. One of the indications changed for a BMI of 40. However, I think the caveat for that is there are many surgeons who do not feel putting a patient on the operating table for any reason whatsoever, unless it is a dire emergency when their BMI is 40. Because there are safety issues, higher risk for lots of different things when you're dealing with somebody who is morbidly obese. They cannot have more than 25% of their apnea be central sleep apnea. So you're like, so what's that? What's central sleep apnea? Central sleep apnea is essentially a kind of complexity to obstructive sleep apnea. It's different in that the brain has bailed. The brain simply doesn't send the signal to the respiratory system to drive you to take that breath. So this is a stimulus for it moves your tongue out of the way to fix your obstruction. It in no way, shape, and form can help anything that's happening neurologically in your brain. So it's not meant for people who have central sleep apnea. Okay. It's not meant for people who have, for instance, some neurological degenerative disease processes, Parkinson's disease. We've had many, many patients who develop dementia over time who have it. And as long as they have good caregivers, they're in a good home where they're either being cared for or their loved ones are with them, somebody else can manage turning it on and off. You don't have to be able to manage turning it off on and off. Finding the remote might be your biggest problem, okay, because you don't know where somebody's put it. So I think I've got that one. It's the obesity. It's 15 to 100. They have to have tried and failed CPAP.
Okay.
Which is the gold standard. Insurance companies want to see that you at least gave it the college try. So what does that mean? Well, there's no real specific guidelines. You either have to be intolerant to it, can't, won't, don't, is the words that I use for the patients. I can't do this. I'm suffocating. I feel like I'm going to die. Okay. I won't do this. There is no way in God's good earth I'm putting that thing on my face. Okay. And don't is I rip it off through the night. I can't keep it on for more than 20 minutes. I find it in the floor every morning. That's not somebody who's doing well with it. Or how about the person who puts on their CPAP religiously every night, religiously wears it all night long, and in the morning still feels like crap.
Mm-hmm.
They still feel terrible. So they're not deriving clinical benefit from CPAP for a number of reasons. You don't have to specify what those reasons are. You just can't, won't, and you don't. You
Okay.
don't get clinical benefit. So those are the perfect patient, and they don't want to have craniofacial corrective surgery. Okay. Many sleep apnea patients have craniofacial corrective surgery because the box is too small, the jars are too far back, their bites are off, there's all kinds of stuff wrong. A craniofacial fix, that's been going on for years and years and years. That maybe they don't want to have double jaw surgery. Maybe they don't want or can't afford to have orthodontic expansion and some of these interventions that are on the market that are out there that are fee for service. Your dental insurance isn't going to pay for them, and your health insurance certainly isn't going to pay for them.
Mm-hmm.
This hypoglossal nerve stimulator implant, like CPAP, like oral appliance to a small extent, are covered under your health care. There are very few carriers that will not pay for it anymore. It used to be in the early days, case-by-case basis, you had to fight for it. But once Medicare realized that they could save billions of dollars on heart attack and stroke care, they approved it. And once it was on Medicare's formulary, all of the insurance companies basically were forced to finally get on board. They didn't have a choice. They couldn't say 10 years into the pipe, it's experimental. It is not.
Mm-hmm.
It is not experimental. It's been around long enough. There are hundreds of thousands of people with this, just like there are pacemakers.
Really, hundreds of thousands of people. This is not a rare treatment.
No, there's patients in all over Europe. They're in Japan now. They're in Singapore now. It's a harder slug to get this in an NIH system. So for instance, trying to get it in England or Canada is tough. And a lot of doctors who live way up north in the United States see a lot of patients who come across the border and pay cash and get it here because they can't get it on the NIH.
Mm-hmm. And is this
Pays for it.
calibrated with a sleep study? So after it's implanted,
Everybody has to have a sleep study. You have to have a sleep study that's less than 2 years old that says your apnea is this. You don't have central sleep apnea. Okay.
I mean, when they calibrate it to set the voltage, how does that work?
Well, the voltage is set based on what they clinically see, because everybody's nerves are different and they're sensitive. But one of the other things I might not have mentioned was the CPAP, trying and failing the CPAP. The other thing was I just had it and I forgot it. There was something I missed as one of the indicators. It'll come back to me in a minute. I just it flew out my brain. So you have to have tried and failed CPAP. You can't have complete concentric collapse of your airway. Okay, so what does that mean? Your airway, if you think of a person lying on their back and you see those pictures of the air where the tongue falls back and it pinches the airway closed. If you think of that, the airway is like somebody stepping on a banana, right? It collapses from front to back. You know, here's your neck and here's your back of your head. Your airway collapses like a banana. But what happens if your airway collapses like a camera shutter? Mm-hmm. Okay, the stimulation is less effective on this kind of a collapse, concentric collapse. Does that mean that patient can't ever get inspired? No, not anymore. Because ear, nose, and throat doctors who really want to provide the best for their patients often do something called a modified UPPP or an expansion pharyngoplasty, which is a nice way of saying we're going to take your camera shutter and turn you into a banana.
Okay.
It tightens up the lateral walls. It's a surgery that tightens up the lateral walls that allows that stiffening of the side walls so that the airway collapses front to back instead of like a camera.
Okay, so in combination, that could work.
So patients can have soft tissue surgery that fails. Lots of times they say, oh, I had a euphilectomy and I had my tonsils out and my adenoids and lots of soft tissue surgery. Over time it fails. And we ask why. Okay, so why does it fail? They told me it would fix my sleep apnea. Well, every day you're a day older. Every single day. You are 1 day older. And your tissues are different today than they were yesterday. And as we age, flaxity, laxity, all of these things, a little bit extra weight, laxity of the tissues, all of that. So that soft tissue surgery you had 10 years ago is no longer helping you with your sleep apnea. And so you got to do something else. And so soft tissue surgery is a piece of the pie. Lots of times you can do combination therapies to get patients over the finish line. Like I said, sleep apnea and therapy is extremely complex. I have provider sleep docs that are friends of mine, good friends of mine, that over their dead body do they think surgery is a good idea, unless it's tonsils and adenoids for children. That's just their thinking.
Tell me about, okay, before we go to combination therapy, because I want to learn about that. I've heard that special populations like patients with Down syndrome may qualify who are younger.
13 to 18 for Down syndrome patients.
Okay, so age 13 to 18.
Because at 18, they become an adult. Then they go into the adult parameters.
Okay, so if you have Down syndrome or if your patient has Down syndrome in the ages range of 13 to 18, they can qualify for Inspire.
And there are certain facilities around the country that do lots and lots of Downs patients, especially the kids.
Wow. That's really interesting. When did that occur? Were they allowed that to push to like that special population at a young age like that?
They were working on children from the get-go. They wanted to have, there are children with Marfan's. There are all kinds of disorders that children in particular have. That Downs was the one that seemed to be the best first target. And they had been working on that all the way back into the 2015-16.
Are there any other special populations that can qualify at a younger age than 18?
Not as that have I've seen on the FDA approval sheets as of yet, but they will come. They will come. And remember, every single change you make to any kind of therapy that requires FDA approval, each change or indication requires the whole brand new FDA approval for it.
Yeah.
So it's a very lengthy, very expensive, very time-consuming process to get therapy to the table for people to actually have access to, and not limited access, but open access to. Unfortunately, Medicare pays for this. Medicaid does not.
Right.
Sadly, they don't pay for quite a few things.
Right.
But that's where part of our healthcare system just fails. That you can only do with what you have.
Right. So, but most other like regular PPO, POS insurances cover. Is it hard to qualify? So I know you've named all the factors to qualify for this treatment. Is it hard to get that approval, or what doctor recommends this? What are the next steps when somebody's interested?
Well, most of the time, the patients start at the sleep medicine doctor. Their primary care might send them over to get their sleep study done with the board-certified sleep medicine doctor. A lot of dentists are, if their state permits them to do home sleep testing and or refer out for sleep testing, so patients are starting there as well. They end up with a diagnosis from a board-certified sleep doc. They have to go in, see somebody, talk to somebody, see if they fit the qualifications. You have to qualify, and you have to have it documented that you tried and failed CPAP or you're intolerant. You have to have documented that you don't have, then that person gets you to the ear, nose, and throat doctor, whoever that sleep doctor is, and says, I want to Inspire. I don't want to do this anymore. I want to Inspire. Most implant physicians are ENTs, ear, nose, and throat doctors, although there are some OMFS doctors who do it. That's oral maxillofacial surgeons who do it. Oral maxillofacial surgeons, though, however, cannot do Medicare patients. At least that's the last I had heard. Okay. So as long as they do anybody but Medicare, they're fine. And the ear, nose, and throat surgeon then will do a comprehensive evaluation, review the sleep studies, possibly rerun sleep studies that they've seen. Many patients who come in with a home sleep study and they have very strong symptoms. We know that the home sleep study gives us an idea that there's something going on at what level. Lots of them are scored at 4%, which is, they're saying that's the new rule. Well, what that does is allow the insurance companies not to treat you, because 4% versus 3% is huge. It's a huge difference. But they may need a test that's more specific. What really is your issue here? And how severe are you? I really personally feel with patients, especially the patients that we treat now, I want to know, I don't want an idea. I want to know, What is the severity and burden of your disease, and what complexity are you as an individual bringing to the table for us to work with? This home sleep study says 14. We've now put you in the lab and added the RERAs, which is respiratory effort related arousals, which is a lot of upper airway resistance type things that the insurance doesn't want to hear about, that made that number of 14 into 41. 14 is, oh, you can kind of sort it. You go, you need antidepressants and it's your problem. You don't really have a sleep problem. Now we're looking, going, okay, you have the potential for a very serious sleep problem that has number of layers like an onion that we need to peel back and decide what piece of this is going to be the obstruction that's going to be taken care of with the Inspire, and what piece of it is it not.
Yes. And do they have to do a DICE, or do they tend to do this?
The next step then, after the comprehensive evaluation and proper testing is done, if that doctor wants anything more specific than just a home test, every doctor has their own guidelines. I tend towards the doctors who want very specific and detailed work. Other people want numbers. It just depends on how you run your practice. And the drug-induced sleep endoscopy is a requirement. And so it's a means by which they mimic sleep with a medication in an outpatient. It's an outpatient surgery center, for instance. They put a little camera down your nose, an endoscope down your nose. And while you're under the medication that they give you that mimics sleep, they're able to see how your airway at the top, the velopharynx, that's up at the top, how it collapses. Does it collapse front to back, or does it collapse like a camera shutter? That's when they'll say, yes, you qualify. No, you don't. Okay. Vast majority of people, I think, in my experience, I did more than 700 DICE easily in 4 years. And I would say only about 7% were concentric.
Okay.
Small population. Most everybody was, yeah, it's fine. CP, you're good.
Okay.
It was very straightforward, very easy. You might have, but you do also find, okay, there's quite a bit of redundant tissue here. Or people don't realize they have tonsils at the top and they also have tonsils down below. And lingual tonsils, which are the ones down below, can really be a problem. They can really block a lot of the airway, and the stimulation isn't going to fix what a lingual tonsil is sitting in the middle of. So those drug-induced sleep endoscopies give us tons of information. Is it used as a diagnostic? No, it's used to rule out concentric collapse. And when it's used by other practitioners, they're seeing how the airway behaves. So they can gauge, for instance, whether maxillomandibular advancement surgery is going to work, because they can advance the jaw and see where, at what point, you get good opening of the airway. So it's a great tool. It's a really good tool. So,
and if on the DICE they do see large lingual tonsils or something more like a soft tissue contributing factor, typically then does the ENT go and address that before even prescribing the Inspire?
Sometimes they do. Sometimes they do. Or what they do with a couple of the guys that I work with, one in particular probably did more than anybody that I work with. So I got, pretty close. And he said, look, let's see how you do with the Inspire. If your first study comes back and it's suboptimal, means it didn't get us where we want, then, because he didn't want to put him through yet another surgery.
Okay.
Wait and see. Let's wait and see. Let's see if this goes great for you for 4 years. And then maybe if you put on a little bit of weight, we might revisit that later. So I think minimizing time under anesthesia, minimizing time for recovery and more surgery, trying to do that is really a good idea. And that's a prudent way to handle it.
How do they determine, though, that what if they just remove lingual tonsils and address soft tissue, the patient wouldn't need the Inspire treatment, perhaps?
You can always try that. But most of the time, children, when you remove tonsils and adenoids, they tend to have their sleep apnea resolve to a large extent. Not always. Not always, and not always perfect. Then that's why expansion and all of the good work that Audrey Yoon and her people are doing comes into play. And earlier the better. Earlier the better. And that's one piece of it. Soft tissue resection, remember, anything that's you take away can come back. Or it doesn't make a difference. So you can't guarantee, none of this you can guarantee that you're going to be perfect at the end. None of it.
Yeah.
This is really good therapy. However, it's not just monotherapy, at least not in my book. I use Inspire for patients who've had maxillomandibular advancement surgery and they come back and they want to be treated 10 years, 12 years later. Maybe they've gained a little weight, maybe their sleep apnea has come back, whatever. They can't be advanced anymore. That's not appropriate. That's not appropriate for them. Even if they wanted it, that's not appropriate care for them. Inspire is a great way to use combination type therapy. Okay. We have patients that use Inspire and their CPAP.
Okay.
Because some folks can't, the stimulation levels are tolerable for most folks to a point.
Mm-hmm.
If you get somebody who maybe pops awake, you're at step number 5 and you're doing great, but your apnea is not really fully controlled. You go to step 6, apnea is fully controlled, but you can't tolerate it. Okay, what do you do with that? What do you do with that? Well, as far as I'm concerned, if they haven't had any previous craniofacial surgery, I'm okay with putting an oral appliance in with somebody with Inspire. Dial it just basically put their teeth end to end, their teeth end to end, put their Inspire on, see how that goes. Because you'd be surprised. All of a sudden, they're getting everything.
So when the machine stimulates the nerve, where exactly is the tongue going?
It goes out into the
between the front teeth.
Goes out the front teeth. It doesn't go to Cleveland. It just goes, it's not going out to Cleveland. It goes out to the border of the teeth, just outside the border.
Just a slight interdental thrust.
Yeah, but there are some people that it goes to Cleveland and others that it doesn't. But no, it's a gentle thing. You're not like, you're not like whipping the tongue out like a snake.
It's not like just knocking across the room. No. So tongue is thrusting straight forward.
So here's your teeth and it kind of goes and then back.
Okay. And then back. What if somebody benefits sleeping with the lips closed versus lips open with Inspire? So if your lips are closed, is that going to negatively or positively impact the treatment and what's happening?
Yeah, it kind of depends. A big part of sleep apnea treatment in general is trying to train people to breathe through their nose and not through their mouth. And that's hard. It's really hard for a lot of people. That's why they have full face masks. I mean, that's why. So it makes it very difficult. But I would say people get creative. I even had patients who insisted on continuing doing their lip taping with their Inspire. And they managed to make it work. So,
so the tongue will kind of come forward. I remember a sleep physician.
Different. Yeah.
Yeah. He said that there was a patient that they could not, the voltage was just maxed out. And the patient was still having apneas, and they brought the patient in with the ENT, and I guess they were doing a DICE, and they're just trying to figure out what to do. And they closed the lips, held the mouth closed, and everything resolved. And he was like, what? I'm like, hello, that's what we do in myofunctional therapy. We know if the lips close, that helps support the jaw and the tongue. So that's just an interesting concept, though, because the tongue is thrusting forward between the teeth. Does the occlusion change for someone who's been on Inspire for a while?
It can. It absolutely can. We had a couple of patients who said that they felt like there was pressure on their lower front teeth and that they were proclining a little bit. But I have never seen any huge occlusal changes. I mean, not like you see with oral appliances. People's teeth go really, their bites change and their teeth move. Lots with oral appliances. Even though they use their AM programmers, deprogrammers and all that, you do see tooth movement. You do see diastemas open up they didn't have before. Tooth movement, bite changes, that's pretty common in those kinds of therapies. But it's part of the thing that you have to tell them, look, I can't tell you this is or isn't going to happen. Statistically, we say, yes, it's going to happen. We just don't know when. You can do whatever you can to avoid it. Continue wearing your retainers. Let's say they still have retainers, or you want to wear your Invisalign trays or whatever. You can do that. I mean, I fully feel like if patients are going to use Inspire, keep your Invisalign trays and keep wearing them because it makes the glide smoother over the teeth anyway for the tongue.
Right. And probably if you've gone to the level where you've selected Inspire as your treatment, I don't want to say it's like a last option, but sort of kind of is, then you probably don't care as much if you're going to have some dental tipping because it's not on your list of priorities probably. So
communication You have people who do inspire and care for inspire patients. I say to my patients a lot, because a lot of them are getting surgery. And I said, be very careful what you're reading on the blogs, Facebook, Twitter, all that stuff. Please be careful, because you're getting a skewed opinion on a lot of things. You're getting information that's half true, half emotional, half didactic, half whatever. And when we're talking to the patients who want to get this kind of hypoglossal nerve stimulation therapy, and they come in and they failed, or they've been told they failed all these other therapies. First of all, they've been told they failed. Okay. Nobody wants to hear that. Okay. Nobody wants to hear you failed anything. Okay. And a big part of what I found myself doing was saying, letting them talk before you even get started about it. Why, for sure, why do you want this? And then see, do you want me to fix this issue? Do you want me to help you? Do you want me to hug you? Or you want me to hear you? 3 different conversations. Which conversation would you like to have first? Because then I think we can find a pathway for you to be successful. Mm-hmm. From a provider standpoint, those are my first 3 questions. Do you want me to help you, hug you, or hear you? And you can put them in any order of preference.
Yeah. And probably some people need all 3 and don't know which one they need, right? Which order?
Yeah, there is no order for some. There is no.
Wow. So, well, for ENTs, is it specific ENTs that provide this treatment?
The ENTs do the surgical installation. Okay, they do the procedure.
They have a specific, obviously, training. Like, how would you find?
No, there are Inspire. It's all you have to do is Google Inspire in my town, and they give you a whole list. You can even contact somebody directly. They've been trained. There's surgeons have been trained. They've been through extensive training. Mm-hmm. They have a lot. They partner with sleep doctors. So the ENTs are surgeons. Mm-hmm. Unless they are both a sleep and an ENT, which there are a number of them that I worked with. So they kind of did the whole thing front to back. Mm-hmm. Then the front piece is the sleep doctor sending you to the surgeon. Surgeon does his thing and then sends you back to the sleep doctor to be followed. You don't go back to the surgeon unless you have a problem. And so the sleep doctors are managing it. And some of them are really, really adept at it.
Okay. So what, how is this effectively monitored in each patient? Is there
utilization is
of their apnea?
No, the readings, their utilization is monitored. Every time they turn their remote off and on, that information goes into the cloud and the doctor has access to it. So every time turn it on and off, as long as you sign the sheet that says you're going to participate. So they know you're using it or you're not. But your actual apnea, what the levels of the apnea are, that's the doctor's going to have to order a new study. Because unlike a CPAP machine, which shows you in the morning that a little green happy face on your button, and then you can read your report that says what your AHI was, this doesn't do that.
Oh, wow. So it just tracks
technology. It just tracks that
you used it. So,
and at what level?
Yes, and a patient would probably need to go back to the doctor if they're not feeling well. It would be based on symptoms or snoring. They shouldn't be snoring using this treatment, right? I mean, except until it turns on. But when it's on,
snoring is greatly reduced. But remember, there are some people who snore through their nose. So they have other things going on in their nose. But snoring is, if you look at all of the studies that have been put out, snoring is tremendously reduced. So people who've been kicked out of the bedroom for years and years are now back in it.
Okay.
Because they're quiet. They're quiet. Yeah, snoring is tremendously reduced in general.
So a change in symptoms would trigger someone to go back to the sleep doctor to get they have
to get a sleep study done after they've been on therapy, and they start you at a very low level of voltage, and then you have the plus button, and every number of days you go up to the next level and you stay there and you acclimate, just like you're going up Everest, right? You don't go to the top the first day. You go a little bit, you wait, see how you do. You go to the next step, you wait, you see how you do. You go to the next step and you're like, that kind of woke me up. So then you go back and you stay at the level down below for a little while longer, and then you try again.
Okay.
And then when you start having your symptoms resolving, you start feeling better. And let's say you make it to level 8 and you're sleeping all night long instead of getting up 8 times to pee, which people do.
Yeah.
All of a sudden you're getting up once in the night, then that's a good indicator that you're ready for a sleep study that will at least tell us how well it's doing. Where are you? Now, it can tell you that your apnea went from 60 to 20. It's not perfect, and you may need to go up 2 more levels to get it down under 10. It gives you a gauge of where you need to go.
And to go up to the level, the doctor is the one that changes that.
He's the one teaching that. Well, you're doing the remote control. You can go up and down at home. What they do is program in the remote control 10 steps.
Oh, okay.
And so you can go and you start them at level 3. So you give them 2 to go backwards just in case they were over ambitious in the office.
Okay. So they can adjust, they can't adjust the start time, but they can adjust on 10 levels of.
Yeah.
Oh, okay. That's interesting. Are there any problems with this treatment or side effects or negative things that could happen?
Well, with any surgery, there's always complications of surgery, which everybody knows there are. There's infection, nerve damage. Neuropraxia used to happen in the very early days when people had numbness and their tongue didn't work real well on the right side afterwards. I think that's hardly ever happens anymore. Hospital infections, you can't do anything about that. Stuff like that. Problems that patients report would be intolerance to the stimulation. That would be one thing, intolerance to the stimulation.
Can I just ask so would that be when you inhale and it triggers a nerve and it causes you to wake up?
It can, right. It can.
That's kind of the intolerance.
Intolerance, right. Pop you awake. I can't go to sleep with it. Insomnia. They wake up. They can't go back to sleep. Soreness on the tongue itself from teeth. So those people, you just a tooth glide or a lower Invisalign tray kind of solves that problem. Okay. I found when I was up at the VA in San Francisco doing some cases, we made a lot of those folks, the lower teeth are pretty ragged and rough, and just make them an Invisalign tray from, first bite to first bite, and then the tongue just went right over it, and no problems. So I have, I think I wrote down somewhere else here. I had a list of a couple, patient complaints are patient complaints, for a number of reasons. If you don't mind me looking at that, let's see.
Sure.
Let's see, dry mouth. Some patients complain of dry mouth.
Okay.
Let me see. Yep. Sometimes they say they can feel the generator moving. That bothers them.
Okay.
Headache, coughing, choking, anything like that. Some people have reported that. But for the most part, the biggest thing is that it wakes them up, keeps them awake, or it wakes them up.
Okay.
That would be the worst one.
What about going through x-rays, like going to the airport or something when you have the implant?
You can go through the airport. You can go through regular standard x-rays. You need to let them know that you have it. The old 3024, which was the very original generator that was put in that long ago and far away, they haven't used those for years. Those were not MRI compatible. The new ones are MRI compatible. The ones that have come out, the 3024s are compatible. You just have to have the right kind of Tesla machine, which now most hospitals have a Tesla machine, so it's not a problem.
Okay. And then Inspire is the main brand, but you said there's other brands around.
I would say it's more than a couple of furlongs ahead of everybody else on the track. It's more than a few furlongs out there. And Nixoa is the next one coming in. Very interesting in that it has put in both sides of the hypoglossal nerve. So for people who have the concentric collapse, that they have better, since they're accessing both sides, they think might be better for treatment for patients who have concentric collapse, that's a great subset of patients that need to be treated. And interestingly enough, the generator is external. This is external. So you tape this little thing under your chin, looks kind of like a hockey puck.
Okay.
That you tape under your chin, and then it goes on, and that's how it works at night. So those have been, I know that a couple of my friends are putting them in.
Like magnetic or something? Like how does it connect?
I think, no, you have a control that turns it off and on, but the actual generator is not inside, it's outside.
Yeah.
This round thing that you tape on it. It's got this little tape.
You tape it. Okay.
It's on your neck. I But I think the idea of having bilateral stimulation, if you have concentric collapse, is really a great idea, because then you're getting it on both sides, and the whole idea is the whole tongue coming forward. That would be great.
Okay, because in the typical Inspire, the tongue will come forward and go out in one direction.
It's only on this side. It's on this side. But what they do is lots of times nerve fibers cross over, and so it does get some bang for your buck on both sides, but not like having it on both sides.
So they implant it on the right side? Is that
usually on the right? Usually on the right, because
the tongue comes out on the right, or it comes forward on the left?
Opposite. So if you're stemmed on the right, goes this way.
Okay. Mm-hmm. Interesting. So you got to see which side your bed partner's on in case they overstimulate you. Go lick them. Okay. So that's interesting. So how did you get started working with Inspire? Or what do you do? Were you part of the surgeries, or what was your role?
Yeah, I was a clinical. I was one of the lead clinicals for the West Coast. So when I first started, I could be in 4 states in 4 days, going to cases. I did a lot of traveling the first few years, and then as they started to grow, then more feet on the ground, and I didn't have to do so much traveling. And went to cadaver labs, helped to train the physicians and then go in the surgeries and be with them and support them, and testing the equipment when you're in the OR. You want to make sure everything works properly before you send somebody home. So doing that, but my favorite piece of all of it was something that they don't do as much anymore, at least the same way. I think the Inspire's changed since I retired. Is that I like the one-on-one care with the patients afterwards, because sometimes they're coming in and they're saying they're not doing well and they don't like it and whatever. And just by virtue of active listening and trying and asking those, kind of in a nice way, asking those same 3 questions, I was actually able to realize that the global piece, sleep is so global and it's so different for every individual. I could pull one of my other very disparate tools out of my bag and use it in connection with their Inspire appointment to help them turn towards being successful for themselves. And so something as simple as, okay, well, let's try. How about we add this? How about we try that? Because it's maybe not the Inspire, but you're focusing on that because that's what you have.
I mean, it's so important to get someone who knows so much about sleep, all the different treatments, who's well-rounded, like you, or somebody who thinks of all these different options. Because if there's somebody doing the procedure and just recommending Inspire, but not looking at all the other pieces to the puzzle, then the success rate is going to be a problem. Right?
It can be. And I know I have, of course, we all have our favorite people that we worked with, at least my group of surgeons and friends. So we did a lot of cases together just because we all like working together so much. And I love that. And it's frustrating and disheartening from the physician's point of view when some of the providers refer you out a patient that they're just frustrated with and they're sick and tired of dealing with this person that's complaining. And like, okay, fine, just go get Inspire. But you're sending me somebody who has rampant insomnia.
Yeah.
This is not the right therapy for somebody with rampant, untreated insomnia.
And what about patients being missed for maybe non-airway related disorders like restless leg syndrome, PLMD, other things might be playing a role, beyond insomnia, narcolepsy.
Well, and that's the big deal. That's my big war cry against having HSTs, because you find so many people have limb movement issues and they have no idea. They're vitamin D deficient. They're iron deficient. Tremendous.
I'm telling you, this comes up in like the last at least 3 podcasts or more that I've done. The ferritin, vitamin D, restless leg syndrome, and I we keep talking about this because this can be missed and it's a big piece of the puzzle. And I was talking with Dr. Simmons and Stacey Ochoa, other people that, like, a lot of kids get diagnosed with ADHD and they might actually be having restless leg syndrome and periodic limb movements in their sleep that's affecting the quality of their sleep. So I feel like it's so important with any sleep apnea treatment to look at all the other components and to have a well-rounded breadth of knowledge to think outside the box.
Well, right. And I think part of this may not be Inspire related per se, but it's very difficult when a patient goes in and they have multiple things that they need to talk to you about. They have multiple issues, multiple problems they're very disparate, and they kind of can't collect it all. They almost don't even know themselves, but they know that there's more than one thing. But I have actually heard a nurse seating a patient who says, well, I want to talk about this and this. And she's like, you can only talk about one of those today. And
pick one.
Pick one. And I'm like, no. I said, I tell the patients, you have your grocery list. You think about something, I want you to write it down at home. I don't care, just keep the list going, because you're going to bring that to your appointment and you're going to say, this is my list. I want you to, because half the time their backs are turned to the patients and they're typing into the computer. They're doing their electronic health note. They're typing into the computer. So they're really glancing over here at Mary, who's like literally sobbing her guts out, trying to tell you what's going on with her, because you've got to get this note done and push send before you walk out the door. You've made up your mind what already is going on with this lady. Yeah. And then you're kind of giving her a cursory, whatever it is. And the patient has to say, stop. Excuse me, this is my grocery list. Please type this in. You're typing right now, sir. Please type it right in, because you now have something. Now that you typed it in, you are bound legally to do something about it.
Mm-hmm.
That's called
you own it. Once you type it, you own it, I guess, right?
Well, it means you must take care of it. And the reason why they don't want you to talk about more than one thing, do you know why?
Why? They have to treat, or?
Coding.
Oh, okay.
I can't code for those two things on the same day. I only get paid for one.
Yes. That's why the medical system is just kind of ridiculous, right? We're driven by numbers.
Understanding that for a patient with Inspire who's very complex, multifaceted, has their issues, maybe the stim is too strong for them. Maybe they need a different bandwidth. Maybe they need another appointment with the ENT to put the scope in while the thing is on and see what's going on. That's important too. So it requires precise follow-up. It requires longitudinal follow-up. Patients, many of the early patients that got Inspire, they felt so great. They're like, oh, I feel great. I'm going on in my life. They come in for something else and you interrogate their device and say, did anybody tell you you're supposed to get this thing checked every year?
Oh.
It's a piece of hardware in your person. You get it checked at least every year minimum.
Mm-hmm.
So it does need to require some fine tuning and maintenance. The batteries are about 11-year lifespan, which is pretty darn good. It's no more difficult than changing a pacemaker battery. It's no big deal.
Okay.
No big deal, because the wires technically should be lifetime. So it's a matter of tiny little incision, pop the battery out, unplug, plug the new one in, close it up. You're in and out of there in half an hour.
Okay. This has been so informative and educational. I feel like I knew about Inspire. I knew what it was, but I did not know all these details. And it's so important for us to all be aware of this as another treatment option that some of our patients may choose to do. I don't believe there's much, if any, research on myofunctional therapy in combination with Inspire. Are you aware of that?
If there is, it's pretty limited. If there's,
so we've got to get that going.
Sure.
I think that would be great to have some research on combining those, because we know pretty much adding myofunctional therapy to any treatment will have the potential to make that treatment more effective. And it would only make sense that it would. So I want to, before I thank you for all of your time, I want to kind of summarize everything as best I can. I take a lot of notes. And it's interesting to me that Inspire just got FDA approved only 10 years ago. So this is, a pretty new treatment, but pretty prolific in its use. Hundreds of thousands of patients around the world are using this. So it's an internationally used treatment. Inspire is the brand name in the United States, but there are other ones, or the main brand name in the United States, but there are some other ones around. And by pushing or thrusting the tongue forward by stimulating the hypoglossal nerve on inhalation, so when the patient inhales, it's going to stimulate the nerve to push the tongue straight out forward between the front teeth. That's how it's opening up the airway.
Out and to the
to the side, out to the left, typically. And it's a 1-day installation procedure. It's a surgery. They're in and out in the same day. How crazy is like modern medicine? I mean, when you just think about this, it's just really, really amazing. After that healing time of a month to 6 weeks, then they go back to the doctor. It gets calibrated, and every year it needs to be checked back on. Patient has a remote control. They turn it on when they go to sleep, and it has a set amount of time it takes until it turns on, because we don't want to start it too early when they're not fully asleep. And then the patient can adjust settings. There's about 10 settings on the remote. They can adjust that on their own. And the efficacy is sort of monitored by patient symptoms, how they're feeling. And and stop me if I'm saying anything wrong, but if the patient is having like a relapse, not feeling well, getting up to use the bathroom 10 times, whatever, they might go back to that doctor for a sleep study. And typically it's ENTs or oral maxillofacial surgeons that might be installing this treatment.
Couple things. One is there's also a pause. There's a pause on the remote control.
Oh, okay.
If
so
they
you
need
get up to use the bathroom,
get up and use the restroom, it's like
good.
Gives you 15 minutes.
Mm-hmm. That's a really good point. Or someone needs to drink water or something. That could be actually scary.
The pause from I think the longest the pause can go is a half an hour. They might have changed it, but it was a half an hour back when I was doing it. 10, 15 minutes is usually what most people need. Definitely. You go to the restroom, get a drink of water, sort of deal.
Okay, that's really good to know. And for qualifications, you need to be 18 years old or older with moderate to severe sleep apnea, AHI 15 to 100. But if someone has Down syndrome, they can qualify at age 13 to 18. There's certain things that will prohibit you from being able to get this treatment if you're obese, your BMI is greater than 40, you have more than 25% central apneas. We don't use it on neurological degenerative diseases. And patients must have tried and failed CPAP or like intolerant to CPAP. It's covered under healthcare insurance for most insurances. And we also don't want concentric collapse. That was another important thing. This is so great. When you said every day you are a day older, that's interesting. Never thought of it that way. That's depressing.
That's my life. That's what I do every day.
Let's not think about that. Let's just ignore that. But I do love a couple things you also said. Go ahead.
One population, though, that we need to remember also is excluded from it or might need to stop using it for a short time is they would prefer it's not indicated for pregnancy.
Oh, good thought. Okay.
Or would you be in a position where you would become pregnant? However, I do know of one of the patients in particular at 46 who ended up having a surprise of life, pregnancy. And she went on CPAP during the pregnancy and then went back on Inspire after she came.
Okay. And they don't have to remove it. They just don't.
Turn off.
Okay. Interesting. Okay. And all patients with sleep disordered breathing, there's layers like an onion, you said, to this diagnosis. And a good question to ask patients, because oftentimes they're overwhelmed, is, do you want me to help you, hug you, or hear you? And that helps us kind of break down. And that means as a provider, you probably have a lot of time scheduled with that patient because that's going to be a long appointment. So actually think before you ask those questions. Typical medical providers.
You don't have to phrase it quite that way.
And many medical providers might say, do you want me to hear you? And you only have one thing you're allowed to say, right? Okay, but that was so wonderful, so interesting. I really appreciate all your time. I do want to mention Airway Circle is a great community. So if people who are listening are not members, I really urge you to become a member of Airway Circle. And there is actually a code to get a 3 months membership, Airway Answers. If you just enter that code, Airway Circle has over 200 recorded lectures. In addition to the podcast I do, the rest of the ladies do Thursday Night Lives every Thursday. Over 200 of them are recorded, and they spend every single Thursday, every single week. I think they've maybe missed a couple from holidays, interviewing people all around the world. And it's just so educational and informative. They also have research folders, private Facebook group, member highlights, global directory of professionals. So it's a wonderful group to be part of. So I really urge everyone, if you're not a member, to consider and look into that membership. And again, I want to thank you so much, Dr. Pat McBride, for being here. It's just so wonderful to be able to talk to you, learn all about other treatment options for patients. You're so informative, so smart. Like I know I'm going to think of more questions. So next time I see you at a conference, I'll have a list.
No problem. No problem. Well, we'll see you at the APMD coming up pretty soon.
APMD coming up, which is always so much fun. So I can't wait to see you then.
You too. Take care.
Thank you so much.
All righty.